Dr. Abrar is an assistant professor in infectious disease pharmacotherapy at the Faculty of Pharmacy of King Abdulaziz University, Saudi. She completed her PGY1 pharmacy residency at Massachusetts General Hospital, Boston, USA, and completed her PGY2 infectious disease pharmacy residency at the University of Houston, Texas, USA. Also, she completed her infectious disease research fellowship at Hartford, USA, and completed a certificate program on infectious disease in adults from Harvard Medical School at USA.
Thank you very much for the introduction. بعد إذنك هعرض presentation in English. هحاول أدخل شوية عربي, but if there are any questions for the audience, feel free إنكم تسألوني أي أسئلة عندكم في نهاية presentation. Okay, so today's presentation is going to be about antibiotic stewardship in acute care settings, a practical guide. So basically, the goal of this presentation is to eventually be able to establish an antimicrobial stewardship and run it effectively. And I'm going to introduce to you a book called Antibiotic Stewardship Playbook, which is basically a guide that was developed by some experts in the United States for implementing antimicrobial stewardship. So for the objectives of this lecture, of this presentation, so by the end of this presentation, you should be able objectives. So by the end of this presentation, you should be able to understand how the playbook can help making antibiotic stewardship practical and learn how to use it. And also to explain how to measure antibiotic utilization. So basically, when you start an antimicrobial stewardship, you should be able to track the antibiotic use in your hospital to make sure that the antibiotic stewardship is being effective. And then the third and the last objective of this lecture is to describe additional strategies for antimicrobial stewardship. So just to provide a brief background of antimicrobial stewardship and antimicrobial resistance. So the concept of antimicrobial stewardship was recently introduced early this century in a way to tackle the issue of antimicrobial resistance, which is a huge global issue that is continually evolving and increasing, where mortality and the death rate is increasing at an alarming rate. So more than 21% of hospital-acquired infections are actually caused by antimicrobial resistance pathogens. And in 2011 in the United States, more than 2 million cases with antimicrobial resistance were reported with an estimated death of 23,000. And this is only, we're talking about the United States. I mean, not to mention what's going on elsewhere in the world. Now, the economic burden, next please. The economic burden of antimicrobial resistance resulted in $18,000 to $29,000 of medical costs per patient in a single fiscal year. So we're talking about these thousands of dollars being spent on one single patient. So if we multiply this number by the 2 million cases that I've just mentioned, then this can actually have a huge impact on the budgets of countries. So one of the very good resources for antimicrobial stewardship was a book that was published by the Centers for Disease Control and Prevention in the United States. It's called Core Elements of Hospital Antibiotic Stewardship Programs, which outlines 7 key elements for successful antimicrobial stewardship program. And I'm going to talk in more details about these elements. So the core elements are leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. And I'm going to speak in further details about each one of these elements in further details in the next coming slides. Now, what is the antibiotic stewardship playbook that I mentioned early in this presentation? And I mentioned that it's the objective, the main objective of this presentation is to be able to know how to use this playbook. So there is an agency in the United States called the National Quality Forum that published a book called Antibiotic Stewardship in Acute Care, a Practical Playbook. And basically it defines itself as being a resource that provides concrete strategies and suggestions for organizations committed to implement successful ASPs or antimicrobial stewardship programs in acute care hospitals. And as I mentioned, it has input from experts from across the United States, which included infectious diseases physicians, infectious diseases pharmacists, microbiologists, and so forth. The target audience for this book is mainly the organizations, including mainly, of course, hospitals, which are the target to implement antimicrobial stewardship, accreditation bodies such as, for example, Sibahi here in Saudi Arabia, and as well as patient and consumer groups. So the book is freely available from the National Quality Forum's website, which is qualityforum.org/NQP/antibiotic_stewardship_playbook. So you can freely download it from there. Now let's talk about each of the three objectives that I mentioned. So the first objective was to understand how the playbook can help making antibiotic stewardship practical and learn how to use it. Okay, so back to the CDC core elements for antimicrobial stewardship programs. And again, also the CDC core elements book is also freely available online on the CDC's website. So if you just go there and type in core elements for antimicrobial stewardship, you will find the book available. So the 7 elements, so I'm going to speak or describe in brief details each of these elements. The first one was leadership commitment, which means that seeking the support, both the financial, the human, and information technology support and resources from the hospital administration, and also getting a full support from the hospital's administration, such as the hospital's president, and so forth. This is very important to ensure continuity of the program. Now, the second core element was accountability, which basically entails appointing a single leader for the program, which is usually an infectious diseases physician. The third element is the drug expertise, which involves appointing a pharmacist leader, preferably an infectious diseases pharmacist. But if an infectious diseases pharmacist is not available, then probably a clinical pharmacist. And this pharmacist will be appointed as a drug expert leader responsible for improving the antibiotic use. Now, after establishing the program, which is headed by a physician and also involves a pharmacist leader, as well as other members such as physicians from other departments, microbiologists, information technology, and so forth, then it would be the time to run and conduct some strategies or and implement some interventions in order to provide antimicrobial stewardship. And this takes us to number 4, which is action, which involves implementing at least one recommended action. For example, antibiotic restriction and pre-authorization, systemic evaluation of ongoing treatment, and so forth. Now, after we implement the interventions and the antimicrobial stewardship strategies, it would be the time to ensure that these strategies are actually meeting the objective of the antimicrobial stewardship. And to do so, we go to element number 5, which is tracking, where we would be monitoring the antibiotic prescribing and resistance patterns in the hospital and see where the hospital is headed. For example, we can compare the resistance patterns between one year and another using the anti-diagram of the hospital, as well as going back and run a medication use evaluation to assess the antibiotic prescribing pattern in the hospital and whether it has improved or not after the implementation of the interventions. Now, after we have tracked and monitored these patterns, it would be important to prepare some reports. This takes us to element number 6, which is reporting, which involves regular reporting of information on antibiotic use as well as resistance. So these reports should be developed and provided to the leadership of the hospital, which basically means the hospital's president. And this provides a proof for the need of antimicrobial stewardship programs and provides like an incentive or motivation for the hospital administration to provide continuous support to these programs. And it's also important to provide these reports to doctors, nurses, as well as relevant staff, particularly throughout education, which takes us to the last and the seventh element, which is education, which pretty much provide education to the hospital staff, whether they are medical residents, fellows, even medical students, as well as pharmacists, physicians, as well as nurses, providing them with the results of the antimicrobial stewardship programs, the reports, and then accordingly provide education about antimicrobial resistance and how to tackle the issue of antimicrobial stewardship and the wise use of antibiotics and avoiding the overuse or misuse of antibiotics. Okay, so how can the National Quality Forum's playbook can help in making antibiotic stewardship practical? So for each of these 7 core elements that were developed by the CDC, the playbook provides 4 things. So the first thing is the brief rationale and overview, why this element is important, and provide a brief description about it. And then the second is providing examples of implementation. So basically, and it divided it into different levels, into basic, intermediate, and advanced approaches. So if you're new into the antimicrobial stewardship world, then you may want to go through each of these steps gradually, starting with the basic, and then once you are established with the basic requirements, then you can go to the intermediate, and then lastly into the advanced. And then the third part, they also provide potential barriers and suggested solutions. So any program, when it's new in a certain hospital, there must be some barriers and problems that antimicrobial stewardship program staff may face. So the playbook provides some of these potential barriers and how to tackle these issues and how to overcome them. And then finally, for each of the core elements, they provide some suggested tools and resources for further reading and further developing the program, such as in the form of journal articles, statements, guidelines, as well as some hospital tools. So I'm going to take one of these 7 core elements and provide an example on how the playbook presents this core elements using the 4 parts that I just mentioned. And I'm going to take drug expertise as an example, since we are here as a pharmacist. So the first part was overview. So the playbook describes the drug expertise as appointing a pharmacist leader to partner with the antibiotic stewardship program leader to provide the expertise and accountability needed for a high quality program. So in summary, basically it just describes the importance of having a pharmacist, as I mentioned, preferably an infectious diseases pharmacist or a clinical pharmacist, to be a leader along with the physician leader in the antimicrobial stewardship program in order to ensure appropriate antibiotic utilization. So for the examples of the implementation, and as I mentioned, the book provides different levels of the implementation to ensure that each new antimicrobial stewardship programs goes from one level to another once they are established. So starting with the basic is to ensure that there is at least a pharmacy leader with expertise in antibiotic stewardship. So first of all, the antimicrobial stewardship should seek a pharmacist who would be appropriate to fill this position, and it's preferred that this person has an experience in antibiotic stewardship. Now, once we have appointed a pharmacist leader, then we can move to the next level, which is intermediate. So this pharmacist, in addition to their experts, they should also be provided with a training in antibiotic stewardship to ensure having a high quality member. And then once this pharmacist has been trained on antibiotic stewardship, then they can engage and train other pharmacist staff into on antibiotic stewardship. So it goes to a higher level from being only one person being trained to different or multiple pharmacists being also trained on antibiotic stewardship. Now, the next part was potential barriers and suggested solutions. One of the biggest barriers on appointing a pharmacy leader is the inability to find a qualified pharmacist. And this is actually true, especially for smaller hospitals where they may not have clinical pharmacists or even infectious diseases pharmacists. So such hospitals may want to consider off-site expert support. For example, appointing an expert antibiotic stewardship pharmacist from a different hospital as a part-time, just to help establishing the antimicrobial stewardship program. Now the next, or appointing or seeking an agency that is experienced in antimicrobial stewardship as well. Now, the fourth and the last part is suggested tools and resources, which is basically it provides a reference of the American Society of Health System Pharmacists statements on the pharmacist's role in antimicrobial stewardship. And there's also actually a dedicated program that was developed by the Society of Infectious Diseases Pharmacists, it's IDP, Antimicrobial Stewardship Certificate Program for Pharmacists, that is available online over a few months. That is very, very helpful for pharmacists. Even those who are not specialized in infectious diseases can actually benefit from such program in order to implement and establish antimicrobial stewardship in their hospitals. Now, the objective number 2 is to explain how to measure antibiotic utilization. Now, once an antimicrobial stewardship program has been developed and established, I'm going to here mention some of the antibiotic utilization measures that can be used as part of the tracking elements. So if you remember, I mentioned the 7 CDC core elements for antibiotic stewardship programs. And the element number 5 was tracking. Which basically means that after we have implemented the interventions or the strategies, we have to go back and or either prospectively track the performance of these interventions, or retrospectively after a certain period of time, we can compare the outcomes after the implementation of the intervention with the outcomes prior to the implementation of the intervention, and see if there is actually an improvement in the antibiotic prescribing and the resistance and in certain measures that I'm going to mention in these details. So each one of these measures can be measured after the implementation, and then compare these measures with those before the implementation of the intervention, and see how different this was and how effective the antibiotic stewardship program was. So the first type of or classification of measures is antibiotic consumption, which basically means how much antibiotics have been prescribed during this certain period. And the most popular measures or parameters that are used include days of therapy, or what we call DOT or DOT, per 1,000 patient days. And then the second one, which was actually introduced by the World Health Organization, is defined daily dose, or DDD, per 1,000 patient days. And if you need further information about how to calculate these two measures, I suggest that you go to the CDC's website as well as the World Health Organization website to know how to calculate these measures in order to run your studies. The second class of measures is the process measures, where you would assess the process of these interventions. For example, assess or evaluate the percentage of cases where antibiotic therapy was appropriate. And this is usually done through some of the studies that we call MUE, or medication use evaluation, where we retrospectively go back and assess whether the antibiotics were prescribed for appropriate indications. For example, if we're talking about one of the broad spectrum antibiotics is meropenem, and when you want to start such a big gun antibiotic or a broad spectrum antibiotic, then you have to establish that there is a necessity for us using this antibiotic. So an appropriate use would be, for example, a person who has been previously infected with a drug-resistant pathogen, a patient who has been hospitalized in the hospital for for a certain period of time. And an inappropriate use would be if it's for a mild skin infection, for example. In that case, its use would consider be inappropriate. So basically, the person who can judge whether the use was appropriate or not would be a person who is specialized in infectious diseases. So such a measure can be assessed and then compared between after the implementation of the intervention and prior to that, and see if the physicians, after being educated and after the intervention has been implemented, whether this has been improved or not. The second point is the appropriate cultures obtained before starting antibiotics. This is a very crucial point because if the microbiological cultures were collected after even the administration of a single dose of antibiotics, one single dose can actually suppress the bacterial growth in microbiological cultures. And this may result in no growth in microbiological cultures. And so in that case, when we don't know which bacteria we are dealing with, then the patient will have to be continued on the broad spectrum antibiotic. And eventually this can result in increasing the risk of antimicrobial resistance, as well as increasing the treatment cost, because usually broad spectrum antibiotics are much more expensive than narrow spectrum antibiotics. So this is very important to assess how much or how many cases where the microbiological specimens were actually collected before the initiation of antibiotic therapy. Number 3 is the adherence to hospital-specific guidelines. Now, every hospital has to establish its own guidelines for different infections based on the international guidelines, and primarily based on the hospital's formulary, because not all antibiotics that are listed in the guidelines are available in each and every hospital, and also based on the resistance pattern that can be obtained from the antibiograms. So each hospital has different resistance pattern than other hospitals. And so the hospital's specific guidelines should be tailored according to the formulary as well as to the antibiogram. And then finally, the timely administration of appropriate antibiotics in cases of suspected sepsis. As you may have heard from the survival sepsis guidelines, that the delay in antibiotic administration can actually result in increased mortality. So for the outcome measures, and these are the most, the easiest actually to be collected, which include the length of stay, how long the patient has been hospitalized or stayed in the ICU, for example, risk-adjusted mortality. So not only assessing the rates of mortality, but also assess what were the risk factors that were associated with this mortality. Was it a certain drug resistance? Was it a certain comorbidity, and so forth? Hospital readmissions for some of the selected infections, such as, for example, for pneumonia or recurrent UTIs. Hospital onset of C. difficile infections, which is primarily a healthcare-associated infection. And it's mainly caused by antibiotic misuse, because antibiotic exposure is actually one of the major risk factors for acquiring Clostridioides difficile infection. And then finally, the adverse drug reactions, basically the adverse effects of antibiotic therapy. As you may know, many antibiotics can be nephrotoxic or neurotoxic. The next type of, or the last type of measures is the financial measures. And as I mentioned early in the background, that antimicrobial resistance is highly resulting in a major impact on the economy. So it's important to measure this from a financial point in order to see how the antimicrobial stewardship is actually improving the economy and the financial status of the hospital. So these include antibiotic cost per patient day, antibiotic cost per admission, as well as the total hospital cost per admission, because the longer the patient is staying in the hospital, this means there will be a more accumulated hospitalization cost on top of the antibiotic expenditure. Now, our last objective is to describe additional strategies for antimicrobial stewardship. So the additional strategies to improve antimicrobial stewardship programs according to the playbook is the first is accreditation and reporting, which basically the playbook suggests or actually highly recommend to follow the standards for antimicrobial stewardship that were developed by accreditation bodies. For example, the Sibahi here in Saudi Arabia. So they have certain standards for antimicrobial stewardship programs. So in order for the hospital to be accredited by this accreditation body, they have to follow these standards and these guidelines. The second thing is the patient education. It's important to educate patients when antibiotics can actually be used, educate them that there is difference between bacterial infections and viral infections, and that antibiotics are only used for bacterial infections, and also educate them why antibiotics are not freely dispensed without prescriptions from the pharmacies. The third strategy is health information technology. It's very important to collaborate with the IT department in the hospital in order to provide data on the outcome measures that I just described in details in terms of the antibiotic use, in terms of the antibiotic use, in terms of the length of stay, the mortality, and so forth. And finally, the quality improvement is to seek experts in the field, whether you have experts in-house in the hospital, infectious diseases pharmacists or physicians with an expertise in antimicrobial stewardship, or from outside the hospital. So here in the conclusions, I'm going to just provide a summary of the three objectives that I mentioned. So my first objective was basically how can the playbook help making antibiotic stewardship practical and how to use it. So the playbook in a very easy language, it provides an assessment and evaluation of a current antimicrobial stewardship program after you establish one, and then apply implementation examples according to your program's needs. It also provides information about some potential barriers and how to look for solutions, and finally utilize resources to fulfill these gaps. So, and how to measure antibiotic utilization. So the antibiotic utilization, it's important to be measured in order to ensure that the antibiotic stewardship is being effective, using a measure from each class of the outcome measures that I mentioned, which included antibiotic utilization measures, process measures, outcome measures, as well as financial measures. It's important to assess the ASP performance based on at least one measure from each of these four classifications. And then lastly is what are some of the additional strategies available for antimicrobial stewardship. As I mentioned, it's important to comply with the accreditation standards, for example, Sibahi's standards for antimicrobial stewardship in order to obtain the accreditation. Also provide a patient education, as well as utilize the health information technology unit in the hospital in order to provide information for the outcome measures. So with that, I conclude my presentation, and thank you for listening.
FADIC, the lifelong learning never stops.